causes inflammation. So usually will be associated with hyperuricemia, but there are some patients who may have normal uric acid levels. So as we always say, diseases don't read textbooks. So most of the time it is associated with hyperuricemia, but sometimes you may do the uric acid levels and they are normal. So what is uric acid? It is a poorly soluble substance that is the major end product of purine metabolism. So remember, your purines basically will be adenine, guanine. They're building blocks of DNA, and they are nitrogenous bases that are found in foods, for example, meat. So this is a purine metabolism pathway. It is a complex pathway, but the main thing you need to remember are these last few steps. So your adenine and your guanine will be converted into all those various things that you did in biochemistry, but eventually they have a common pathway that will involve hypoxanthine being metabolized into xanthine, and then xanthine into uric acid. And this is the most important enzyme to remember, the xanthine oxidase. Keep that in mind. It is what will change xanthine into uric acid. So we'll be looking at some of the drugs that inhibit this enzyme so that you do not form the uric acid. Now, in other animals, apart from human beings, they actually have an enzyme known as uricase that will further convert that uric acid into allantoin that is very soluble and is easily excreted. So we'll be looking again at agents that work like uricase. So how do you get hyperuricemia? Either your patient is an overproducer, so they're producing too much uric acid, maybe because they're taking in too much of the meats that are then converted into the purines that then form the uric acid. So those are the overproducers. But then you can have those patients who are not producing too much, they're just producing normal amounts, but they are under excreting. So this uric acid usually will need to be filtered in the kidney, in the glomerulus. It undergoes glomerular filtration 100%. 98 to 100% is then reabsorbed and then needs to be secreted back into the tubule, and then there's further reabsorption, and eventually only about 7 to 12% is excreted. So there are patients who may not secrete as much, so they have under excretion of the uric acid. So you need to understand your patient. Is your patient an overproducer, so you want to inhibit xanthine oxidase, or is your patient an under secretor where you actually want to give them agents that we call uricosuric agents that help them to secrete a lot of the uric acid out through the urine. So before we begin the drugs, you need to understand the pathogenesis of the acute gout. So we've talked about how you get the hyperuricemia. When you have got excessive levels in the blood, they then precipitate, and they like the joints because it's cooler in the joints. So that's where they precipitate, because the temperature is a bit lower compared to the central compartments. So once they precipitate as urate crystals within the joints, you then have, this is a foreign object really within the joint. So you have activation of your immune system. So you have activation of mast cells and activation of the endothelium itself, which then leads to production of chemokines, which will now lead to influx of neutrophils into the joint, and that is what will cause the synovitis or the inflammation of the joint. So for you to manage gout, you need to reduce the uric acid levels. But if your patient has already come in with an acute gouty attack, what you want to do at that point is to actually reduce the inflammation. So you'll see that the drugs that are used for acute gout are mainly to control inflammation. Then the drugs that are used for chronic gout are the ones that are reducing hyperuricemia. It is very important to have that distinction in your mind. So the aims of gout treatment: one, your patient coming in with pain, he just wants to get rid of the pain at that particular point. So number one, to relieve the acute gouty attack. But then you always have to remember that even if you deal with the acute attack, your patient will still come back if you don't deal with the underlying condition, which is excessive uric acid. So you want to prevent recurrent gouty episodes by reducing the uric acid levels in that patient. Then finally, you want to prevent the long-term complications of having excessive uric acid. This uric acid, remember, is being excreted through the kidneys. So when you have excessive levels, they can precipitate in the kidneys, forming uric acid stones or urate lithiasis. So these are the goals when you're treating gout. Relieve an acute attack, prevent recurrence, and prevent complications. So finally, I now begin with the agents that are used in management of gout. For the acute gout, remember we want to deal with inflammation. So you'll use anti-inflammatory agents. Examples are colchicine, your non-steroidal anti-inflammatory drugs, and steroids, and we'll go through each of them. For chronic gout, you want to reduce the uric acid levels. So either A, you use the xanthine oxidase inhibitors, which will prevent conversion of xanthine into uric acid, or you use uricosuric drugs that increase excretion of the uric acid through the kidneys, or you give the patient uricase that will convert. Okay, whoever is making noise in the background, please just mute so we have a smooth class. Third group of agents you would use is uricase, which will basically convert your uric acid into a lantoin that is very soluble and very excreted. So we start off with the details for management of acute gout. Number one, this is actually the first line agent, is colchicine. So colchicine is available as an oral formulation. It's readily absorbed. It can be given with or without food because the absorption is not affected by food. In terms of the other pharmacokinetics, it has a large volume of distribution. It undergoes significant enterohepatic circulation, and its half-life is actually quite long. It has a half-life of about 31 hours because of that enterohepatic circulation that keeps it in the system. Excretion is via both urine and stool. And you should be aware that it is contraindicated if your patient has got significant hepatic or renal impairment. For the metabolism, it's metabolized by cytochrome P3A4. It's also important to remember that it is a substrate of the P-glycoprotein efflux pump. Remember, this is a pump that is found within the intestinal mucosa that removes drug out of the body back into the intestinal lumen. So it's important to remember that it is a substrate of that pump. So some of it will be removed and it goes back into the intestinal lumen for excretion through the stool. So if you're giving it at the same time you're giving a P-glycoprotein efflux pump inhibitor, that means you can actually have increased levels of the colchicine in the blood. For the pharmacodynamics, how does it achieve its anti-inflammatory effect? It actually works directly within the leukocytes. It inhibits tubulin polymerization within the leukocytes, and that then inhibits leukocyte migration. So the leukocytes are not able to migrate into the joints where the inflammation is taking place. So that is the major mechanism of action. Number two, it also reduces secretion of these chemokines that are basically the agents that attract neutrophils and other inflammatory cells into the joint. Then it inhibits formation of other chemotactic factors such as interleukin-1 and interleukin-18. So it is acting both on the inflammatory cells and also on the cytokines that are calling in the inflammatory cells into the joint. So the main use will be in an acute gout flare, and I say that it is one of the first-line agents because it actually reduces the pain and swelling within 12 hours. So your patient will really thank you because this thing is really painful. So within 12 hours, colchicine will reduce the pain and swelling with actual complete resolution of the pain and swelling within 48 to 72 hours. It should be given early in the course of the disease. So within 24 hours of the patient having the acute attack, that is the best time to give it, within 24 hours of attack onset. The dose, usually it's given at 1.2 milligrams at the first sign of, if a patient will know when an acute gout attack is coming. So at the first sign of pain, of swelling, they take 1.2 milligrams. Then thereafter, it's given at a dose of 0.6 milligrams twice a day. In Kenya, these are actually doses for Europe. In Kenya, we actually have it available as 1 milligram and 0.5 milligrams. Apart from using acute gout, you can also use it as prophylaxis for acute gout. So in a patient who you're using the uric acid lowering therapies, as you lower the uric acid in the blood, you actually have mobilization of uric acid from other tissues where it is stored. So those patients may actually be at increased risk.
I'm just writing important things that aren't in the slide.
I'll also share the slides, guys, and please don't interrupt the class. Tafadhali, just mute. We go smoothly. I will share the slides. You will have time to ask questions. Sawa sawa. Adverse effects associated with colchicine. This is a must remember slide, because if you're not careful with colchicine, you will have severe diarrhea. So the doses I've talked about have to be adhered to exactly. Otherwise, your patient comes in with very bad diarrhea. They also get nausea, vomiting, and abdominal pain. So those are the earliest signs of impending toxicity, and you must warn your patient about it. They start having diarrhea, they need to stop the drug immediately. Other less common adverse effects include hepatic necrosis, acute renal failure, and seizures. And even more rare will be alopecia, suppression of the bone marrow, and breakdown of skeletal muscle, also known as rhabdomyolysis. But the most important to remember are the GIT ones: diarrhea, nausea, and vomiting. Please warn your patient if they get any sign of diarrhea to stop the drug immediately. With colchicine overdose, someone who maybe takes double, triple, or quadruple of the dose, maybe out of not knowing, or they're trying to commit suicide. What are the clinical effects of colchicine overdose? It starts off with a burning throat pain, then they develop bloody diarrhea. The diarrhea can be so much that they get intravascular collapse, so they go into shock. They may also have hematuria, or blood in the urine, and eventual acute kidney injury with reduced urine output, also known as oliguria. Drug interactions, I already alluded to this. If it is combined with a P-glycoprotein inhibitor, then you're not having efflux of the drug into the intestine for excretion, so you have excessive levels in the blood, so you get toxicity. Also, remember, it's metabolized by cytochrome P3A4, so if given together with a 3A4 inhibitor, again, the levels in the blood will rise and you get toxicity. So it is important to know the full list of drugs that your patient is on. Remember, this is usually be an older patient who may have comorbidities, hypertension, diabetes, etc. So you must check what other medications your patient is on. So that is colchicine. I move on to NSAIDs. NSAIDs you have probably already covered in other lectures. You've covered extensively, so I'll just mention this in passing. How do they help in patients with acute gout? They will inhibit prostaglandin synthase. They will also inhibit phagocytosis of the urate crystals by the neutrophils and other inflammatory cells within the joint. Usually we prefer other NSAIDs like you can use ibuprofen, you can use diclofenac, aceclofenac, all those are okay. Aspirin, not usually used because you need to know the correct dosing. So the issue with aspirin is that at low doses, if you're using less than 2.6 grams per day, it actually leads to retention of uric acid. So you're worsening the situation if you use low dose aspirin. However, if you're using very high doses, more than 3.6 grams per day, it then becomes uricosuric, which means that you now increase secretion of uric acid into the urine. So this is a common MCQ, so you need to know low doses lead to retention, higher doses are uricosuric for aspirin. Glucocorticoids, again, this is a topic extensively covered elsewhere. We keep going through corticosteroids all the time. So what is their role in management of acute gout? If your patient has got severe symptomatic gout, you can actually use parenteral therapies such as glucocorticoids. So in a patient maybe who's not able to tolerate your colchicine, or they have maybe peptic ulcer disease, they're not able to tolerate the NSAIDs, you can actually inject the glucocorticoid into the joint. So remember I said it's not only the big toe. Gout can even present any joint. So if your patient has got the gouty attack and it's involving a large joint, you can inject glucocorticoids into the joint. It's very it has a lot of discomfort, the injection, but the relief is also very good with the intra-articular injection. They can also be given systemically, so we are talking about IV, or you can use subcutaneous routes. An example of a glucocorticoid that may be commonly used is oral prednisone. You start at pretty high doses, about 30 to 50 milligrams per day. You give that for 1 to 2 days, then you taper off slowly over a week. Which steroid can you inject intra-articularly? You can use triamcinolone. Triamcinolone can be given as an intra-articular injection. So I've taken you through management of your patient coming in, screaming in pain. After you have managed that acute condition, remember to always deal with the underlying pathology. Underlying pathology being that your patient has got hyperuricemia. So how do you resolve that in the long term? So we start off with xanthine oxidase inhibitors. The most commonly used, one of the oldest drugs, is allopurinol. So it is the preferred therapy for gout in the intercritical period, and this is basically the period between acute attacks. So you want to lower the uric acid levels so that actually your patient is less prone to getting the recurrent gouty attacks. So how does it reduce the uric acid in the body? It does so by inhibiting xanthine oxidase that we've already mentioned. So you then don't have conversion of your hypoxanthine into xanthine and then xanthine into uric acid. So it stops that production or reduces the production of uric acid from your purines. Allopurinol is actually an analog of hypoxanthine. That's why it's able to bind to the same enzyme and inhibit it. It's not active itself. It's actually a prodrug that needs to be metabolized to the active metabolite that is known as oxypurinol. So oxypurinol then is an analog of xanthine. So it looks just like xanthine, is able to bind the same enzyme, xanthine oxidase, and inhibit it. Now, the oxypurinol actually has a much longer half-life. It's able to persist for a long time in the tissues, and so it is the one responsible for most of the pharmacologic effects of allopurinol. Allopurinol is given orally. 80% will be absorbed after oral administration. In terms of its distribution, it's not bound to plasma proteins, so it circulates free. Excretion is via the urine. The half-life, as I've alluded to before, oxypurinol half-life is much longer. So the half-life of oxypurinol will range from 18 to 30 hours, whereas allopurinol, the original molecule, half-life is only 1 to 2 hours. Allopurinol will usually be given OD. Start doses, you can start from as low as 100 and titrate upwards all the way to even 900 milligrams a day. So the uses, it will be very useful for management of the hyperuricemia in patients with gout. But as I've said before, the urate or uric acid lowering therapy, you don't usually give it during the acute attack. For the acute attack, just first manage the inflammation. Thereafter, a week later, you can then start the uric acid lowering therapy. You don't want to start lowering the uric acid during an acute attack because you may worsen the attack, because as you lower the uric acid levels in blood, like I said before, you then have mobilization of uric acid from other tissues other than the joint. Other tissues where the uric acid has been stored will be mobilized back into the bloodstream, and then now because the joints are cooler, they have a cooler temperature, it keeps precipitating in the joints. So that's why we are not lowering uric acid during an acute attack. Number 2, you can use it to prevent hyperuricemia in patients who have got hematologic malignancies. So as you rotate in the wards, you'll be seeing a lot of patients with leukemias, lymphomas. So these particular malignancies, when you begin giving chemotherapy, the chemotherapy starts to destroy the malignant cells very fast. Once you start destroying cells, you actually have release of the intracellular contents, including uric acid, into the bloodstream. That is what is called tumor lysis syndrome, where you have given chemotherapy to a patient with a cancer, a hematologic malignancy. Once you give the chemotherapy, you start having breakdown of the malignant cells. As you have breakdown of the malignant cells, you have release of intracellular components into the bloodstream. This includes potassium, phosphate, and even uric acid. So to reduce that risk of tumor lysis syndrome, where you'll have elevated uric acid from the breakdown of the cells, you then give allopurinol as prophylaxis. Number 3, you'll use it to dissolve gouty tophi. And here I have a photo of a patient who has got gouty tophi. You can see it's basically a swelling because of excessive precipitation of the uric acid that causes such swelling. So someone can have such a swelling on the elbow, it can be on the toe. So to dissolve this, you actually give long-term uric acid lowering therapy, for example, with allopurinol. So this is what I've said before, that the incidence of acute attacks of gout may increase during the early months of allopurinol therapy, because as you lower the uric acid in blood, you have mobilization of tissue stores of uric acid. Once they get into the bloodstream, then they get to the joints where it's cooler, they keep precipitating. Yeah. So to reduce these attacks, you can actually co-administer the allopurinol with your colchicine to prevent those recurrent acute attacks. Adverse effects that are associated with allopurinol, you can get hypersensitivity reactions that basically will present as a skin rash that can be so bad that it develops into Steven-Johnson syndrome. I should actually have put up a photo of SJS. It's a pretty bad condition where you have got blistering and denudation of the skin. If it's less than 30% of the body surface area involved, that is called SJS. But once you start getting more than 30% of the skin involvement, then you're calling it TENS, or toxic epidermal necrolysis. So it's a very severe condition that can lead to death, because now you start losing fluids through the skin. So this, you need to remember this, that allopurinol can actually cause very severe skin hypersensitivity reactions. So if your patient starts complaining of a skin rash, just stop the drug and change to something else, because that rash can develop into something very severe known as SJS. Other adverse effects will be your GI adverse effects. It can also cause a peripheral neuritis. It can suppress the bone marrow. It can cause hepatic toxicity. Rarely in the eye, it can cause cataracts in the lens of the eye. I move on to febuxostat. Febuxostat is a newer agent. I think it came out in the last 5 to 10 years. It's rapidly gaining popularity. It works the same way as allopurinol, so it's also a xanthine oxidase inhibitor. It's also given orally. More than 80% will be absorbed following oral administration. Half-life is about 5 to 8 hours. Metabolism is via both oxidation and then subsequent conjugation with final excretion in the urine. So just like what we've said with allopurinol, as you start giving allopurinol and lowering the uric acid, you may actually also want to give prophylaxis for acute flares with either colchicine or NSAIDs to avoid the precipitation of the uric acid in the joints. A patient on febuxostat, you should monitor the liver function tests, at least do the liver function tests monthly in the first 3 months, then thereafter you can do it every 6 months. So it is associated with liver function abnormalities. It may cause diarrhea, headache, nausea, joint pains, and a skin rash as well. For the drug interactions of febuxostat, so any drug that is metabolized by xanthine oxidase, there will be a drug interaction. So there are actually drugs that are metabolized by xanthine oxidase. This includes theophylline. Theophylline is used in asthma. You have got mercaptopurine and azathioprine. So these are drugs that part of their metabolism involves xanthine oxidase. So obviously, if you give it with a xanthine oxidase inhibitor, that means that the levels of these drugs will increase because they will have less metabolism. So especially to remember is the azathioprine, because if you get increased levels of azathioprine or mercaptopurine, you then have the adverse effects, and specifically with azathioprine, we're talking about bone marrow suppression that can be very severe. So febuxostat should not be given in a patient who is on mercaptopurine or on azathioprine, because you can then get the adverse effects of these drugs due to their increased levels. If you must administer it in a patient who is on theophylline for their asthma, you should exercise due care and you can even have monitoring of theophylline levels so that you keep reducing the dose of theophylline that you're giving. So those drug interactions are extremely important to remember. So I pause there. We've looked at acute gout. We're now looking at chronic gout. We have looked at agents that inhibit xanthine oxidase. So this will be very important in an overproducer of uric acid. A patient who's producing too much uric acid, you want to reduce the production by inhibiting xanthine oxidase. Now, what do you do with a patient who is an under-excreter? A patient, you look at the uric acid levels in the urine. You can actually do such tests, and the uric acid levels are very low. So they are under-excreting the uric acid. For such patients, then you use uricosuric agents. So by way of introduction, remember that the uric acid undergoes glomerular filtration in the kidney. Some is reabsorbed, then it needs to be secreted back into the lumen. Then you have further reabsorption, with finally you excreting about 8 to 12%. So most of it will be reabsorbed, with only about, on average, 10% being excreted. Now, what are the transport proteins that are involved in its reabsorption back into the body from the kidney tubules? So reabsorption is via a transporter called URAT1. URAT1 is a member of the organic anion transporters, or the OAT family. So that is what will exchange urate. You will reabsorb the urate in exchange for organic anions such as lactate. So you're basically reabsorbing urate and then secreting out lactate. Now the uricosuric agents will now come in and compete with urate for that transporter. So they're inhibiting reabsorption of uric acid via the URAT1 transporter. So instead of reabsorbing the urate, you're then reabsorbing these agents such that the urate is left within the tubular lumen and then excreted in the urine. So these uricosuric agents, they include probenecid, sulfenpyrazone, benzbromaron, like we said before, high-dose aspirin, and lesinurad. So they will inhibit urate reabsorption via the urate anion exchanger system that we are calling URAT1. So they're very good for increasing the excretion of the uric acid in the urine. But then now, when you have got too much uric acid within the urinary system, again, you reach a saturation point where they again start to crystallize and precipitate. So they may lead to increased risk of uric acid stones within the kidney. So any patient that you put on a uricosuric agent, you must tell them to increase their water intake so that you're diluting the urine, so the uric acid does not precipitate within the tubules and form uric acid stones. So that is extremely important to remember. Prescribe the probenecid, prescribe the benzbromaron, but remember to tell your patient to concomitantly increase their fluid intake to prevent risk of uric acid renal stones. So probenecid, basically in terms of its chemical structure, it's a derivative of benzoic acid. It's highly lipid soluble, given orally, and it is completely absorbed. About 95% will be bound to plasma proteins. And then when it reaches the kidneys, the free fraction will be cleared by both glomerular filtration and active secretion within the tubules. When will you use probenecid? If you are convinced that your patient is an under-excreter of uric acid. Again, you don't want to start the uric acid lowering therapy immediately during an acute attack. So wait for at least 2 weeks after the attack for you to start lowering the uric acid using your uricosuric agents. Adverse effects associated with probenecid, again, it may cause GI irritation, it may cause a rash, it may suppress the bone marrow and cause aplastic anemia. And in the kidneys, you may get nephrotic syndrome. Nephrotic syndrome is basically where you're losing a lot of protein through the urine. So you get a leaky glomerular basement membrane in the kidneys. So then you're leaking a lot of proteins. I've already alluded to this. You must maintain a large urine volume to minimize stone formation. So increase out intake of their fluids. At least take up more than 3 liters of water in a day to prevent these stones. Lesinurad is another uricosuric agent. It's a newer agent. Probenecid is very old. Now we have newer agents such as lesinurad. Usually it will be combined with a xanthine oxidase inhibitor. Let me just stop there and ask anyone to tell me an example of a xanthine oxidase inhibitor so I know we are together. Any example of a xanthine oxidase inhibitor? Anybody? Please unmute.
Allopurinol.
Oh, thank you so much. Allopurinol. And another one? The newer one that starts with an F, febuxostat. Thank you. Excellent. So if your patient has got monotherapy with febuxostat or allopurinol, and you're not quite able to achieve the uric acid lowering effect that you want, you can then combine forces. You can use the febuxostat plus lesinurad. So now you're having 2 places where you're lowering your uric acid, you're reducing production, and you're also increasing excretion. So don't get frustrated if your patient, even when you've increased doses of allopurinol and you're still not getting anywhere, you can always add on a uricosuric agent such as lesinurad. At this point, also let me mention that we do a lot of drugs, but please remember also lifestyle interventions. So your patient with gout must be told to reduce their intake of the red meats. Bioavailability of lesinurad is 100%. It is 98% protein bound. Half-life is 5 hours, and it inhibits both URAT1 and one of the other organic anion transporters known as OAT4. So it may actually be more efficacious than probenecid because it's inhibiting 2 transporters. contraindicated in moderate to severe renal impairment. So that is lesinurad. It may cause acute renal failure, may cause nephrolithiasis with the uric acid stones, and then other symptoms include flu-like symptoms and even gastroesophageal reflux. So far we have reduced production of uric acid. We have increased its excretion. Finally, we want to give uricase, which remember I said is not found in human beings, but other animals actually have got uricase that will convert the uric acid into allantoin. And then the allantoin is more soluble, more of it is excreted out of the body compared to uric acid. So we are basically giving synthetic uricase to break down the uric acid into allantoin. Now, these agents, first of all, let me mention, they're very rare in Kenya and they're very expensive. So these will be patients who are now at the end of the spectrum. You've tried all the drugs we've talked about before. You're not getting anywhere. Now, we're calling that refractory hyperuricemia. Then now you can get to pegloticase. So we've already talked about this. Uricase will catalyze oxidation of uric acid into allantoin. It's more soluble, easily excreted, and it's also inactive. So pegloticase is called pegloticase because it is basically the uricase enzyme that's been made synthetically, and then it's pegylated, which basically increases its half-life. It's given via infusion, so this is not something that you take orally. It has to be given via an IV infusion. Like I've said before, it's used in treatment of refractory chronic gout. You're just not achieving reduced levels, even with combination therapy with xanthine oxidase inhibitors plus uricosuric agents. Now, the problem with this agent, number one, I've already said it's pretty expensive. Number two is that because it is basically it looks like a protein. It's a uricase. It's a peptide protein. 90% of patients will now start seeing it as a foreign body and start producing antibodies against it. So 90% of patients will develop antibodies against the pegloticase. So it will lower the uric acid nicely the first 1, 2, 3 treatments. Then after that, you just see the efficacy dropping because your patient is now producing antibodies against it. So that then leads to loss of its urate lowering effect because of the anti-pegloticase antibodies. You need to be very careful when infusing it. It may cause infusion reactions that you then need to stop the infusion and give antihistamines and steroids to control that. It may cause overt anaphylaxis, so a very severe allergic reaction that may even lead to death. So a patient who is on infusion of it needs to be on constant monitoring of their vitals and all their organs. Patients who have got glucose 6-phosphate dehydrogenase deficiency may be prone to hemolysis. Then you can get chest pain, diarrhea, and nausea. But you need to remember about the infusion reactions because these can be life-threatening. Final drug of the day is rasburicase. Rasburicase is also a recombinant uricase. When we say recombinant, you're basically injecting the DNA material that is coding for uricase into another organism or another cell line, and then it produces the uricase. Mainly, it will be used in prevention of tumor lysis syndrome in patients who have got malignancies. Remember, as you give the chemotherapy, you start breaking down cells, then you get increased uric acid levels. So you can use rasburicase to prevent that tumor lysis syndrome. You can also, the problem with it, just like with pegloticase, you can get formation of antibodies against it. So that is another reason why they're not used very commonly. I open the floor for questions. I will send these slides. I will also send a review article that I have written on the topic that you can read about tomorrow. You also have you're supposed to have another session tomorrow. I'll give you that time to read through these slides and also read through that article that will help you in your management of gout patients. Questions are welcome.
I have a question.
Yes, please.
How do you know the difference between an undersecretor and a person who's overproducing the uric acid? Do the symptoms manifest differently?
They do not. They do not. So, like I mentioned, you would have to do the uric acid levels in the urine, right? We said you expect about 8 to 12%, on average 10% of uric acid being excreted. So you know the serum uric acid, then now you see what percentage of that is being excreted through the urine by measuring the uric acid in the urine. Sawa. Then you get an idea, is this a normal excreter? So basically they are an overproducer, or are they an undersecretor? Are they secreting less than 10% of what they're supposed to be secreting? But this is not commonly done, I must say. Yeah, but the symptoms will be the same. You will not be able to know from the symptoms.
Okay, thank you.
You're welcome.
Good morning.
Good morning.
I had a concern.
Yes.
What's the market name for colchicine?
The market name for colchicine. Imagine
Yes.
we don't even teach you the market names, because then we become marketers for the different companies. So anyone teaching you market names is not doing the correct thing. Sawa. Even when you're prescribing, please step away from prescribing, augmenting, or prescribing. Yeah, just write the correct name. So for colchicine, just write colchicine 0.5 milligrams BD. That is all. Yeah. Okay. So I'm sorry, I'm not able to tell you the market name, because we are not supposed to market for anyone.
Okay.
What was your concern there? Because all you need to know is colchicine. Like, tell me your concern so that I address it. Do you have a patient on colchicine that you want to know whether it's colchicine or?
No, I just wanted to know the effective colchicine product market.
You have heard my concern though. Tumeelewana? Yeah.
So
cool. Okay, guys, slides coming in a few.